Joining us is Dr. Paryani. He is a board certified medical oncologist. He practices at Duke University Hospital, and he takes care of women who are going through breast cancer treatment. We know that in the community, there's a lot of conversations about breast health, breast implants, and mammograms. And we saw this as a really important opportunity for us to bring this information to you so that you are getting facts and not making fear-based decisions. Our goal today is to share this education. Of course, it's not medical advice, but it's a wonderful opportunity for us to address these myths and give you as our members opportunities to ask questions in our live feed below. So, Dr. Paryani, I'd like to pass it over to you. Can you share with us a little bit about your educational background, your training, the kinds of women you're taking care of every day, and then also, how did you find Bustmob?
Absolutely. Thank you so much for having me. I really appreciate it. I'm very excited for any opportunity to talk about breast cancer related things. And I think screening is just critically important because the best part about breast cancer would be getting rid of it forever, right? So I'm 42 years old. I moved to Raleigh about 6 years ago. Duke is my first job out of fellowship where I trained at Winston-Salem at Wake Forest University. I did my residency in Kentucky. And we just have fallen in love with North Carolina. I made a few really good friends at Amelia, and I just really respect what the practice has done for the women of our community. I always knew I was going to be an oncologist from a young age. I lost my youngest aunt to breast cancer when I was 12, and she was 42. So this year especially has had me thinking a lot about the journey and how far we've come, but there's still a lot of work to do. And I think it really truly starts from the ground up, which is screening and finding this early and saving lives.
Thank you so much for sharing that. We feel the same way. We know that screening is critically important, but we also know that there's a lot of misinformation about it. And some of that misinformation can sound really scary and may delay women from getting screening. So while we're answering these questions today, you are so kindly shared your time with us to give us these expert opinions and help us understand some of this like medical jargon and help us make sense of everything. And we're really passionate about informed women making decisions that are, aligned with their lifestyle choices. So what we're going to do is we're going to take the conversations right out of Bustmob, the questions that we see posted, and also talk about some of the myths that we see. And you can let us know, are they true or are they myths or not? So we're really excited. And then also, if time allows, we have this live chat down below that we'll be pulling questions from. So anybody who's kind enough to join us today, please feel free to submit your questions into the chat. And Dr. Paryani will have an opportunity to answer them. So if that sounds good to you, we'll get started.
Let's get it.
All right, let's do it. So I'd like to start out with just what is a mammogram? How do they work, and what even are the screening guidelines?
Absolutely. So a mammogram is a specialized X-ray of your breast, and it can detect breast cancer early, oftentimes years before you can even feel a lump. So during a mammogram, the breast is just gently compressed between two plates, and then X-ray images are taken. The compression really helps to create a clearer picture, and it uses a lot less radiation than it used to. So there's two main types of mammograms. There's digital mammography, and that takes a 2D flat image of the breast. And then 3D mammography, that's what in medicine we call tomosynthesis. You'll see that word. That's taking multiple images from different angles to make a 3D picture of the breast. And that is now the gold standard. Studies have shown that 3D mammograms are much better at finding cancers and having actually fewer false alarms than 2D mammograms alone. So most of the imaging centers nowadays are all doing 3D mammograms. In oncology specifically, so I'm coming with a little bit of a different background than plastic surgery. My background's oncology. So most of our oncology and in general healthcare, internal medicine, preventative health guidelines, they vary a little bit on their recommendations. So the United States Preventative Task Force, their most recent recommendation from 2024 recommended screening every 2 years starting at age 40. But the American Cancer Society recommends yearly screening starting at either age 40 or 45. And the American College of Radiology and the National Comprehensive Cancer Network recommend yearly screening at 40. I think, all cancers, we just heard about, James Van Der Beek. I mean, so many young people are affected with cancer, and people are living longer and healthier than they ever did before. So Most of us are favoring the aggressive early approach, which is start at age 40 and do an annual screening mammogram, especially if you have other risk factors. So things like family history of breast cancer, like your mom or your sister, people with that kind of history, they should probably even think about starting earlier, sometimes even 10 years before their youngest family member was diagnosed. So a lot of wide recommendations, but usually age 40 once a year is the most up-to-date consensus right now in America.
Got it. Thank you. I've heard all different ages, so that's really helpful. When we're talking about these things, like decisions that we make for our own health, there's always a what if you do it and what if you don't do it. Can you share a little bit about what we know about patients who decide they don't want to participate in those screenings?
Absolutely. So we know regular mammograms save lives. There's just no debate about that. There was actually a really recent study. It was a big study published in JAMA, which is the Journal of the American Medical Association, and that was from last year in 2025. And so that had 400,000 women, and what it found was that those who skipped their mammograms had a 40% higher chance of dying from breast cancer over a 25-year period. That's huge. And that's as bold and as blunt as it gets. Cancer rates are similar between women who got mammograms and those who didn't, but women who skipped screening were diagnosed at higher stages. So that's more chance that the cancer was hard to treat or could actually kill them. Women in that study who had skipped screening had a 53% higher rate of being diagnosed at stage 3 and a 261% increase in being diagnosed at stage 4, which is metastatic breast cancer. Yeah. And metastatic breast cancer, unfortunately, still today is not curable. It is treatable, but it is 100% lethal at some point. So the point is, the earlier breast cancer is found, the better your chances are. And screening finds those cancers when they're small, easy to treat, and it can significantly improve survival.
Wow, that's very sobering to hear that, especially what you just shared about metastatic disease, that once it's progressed to that point, that your outcome is very different. So essentially what you're saying is there's no difference in people getting cancer, whether or not they're screened. The big difference is how early it can be detected.
That's an important distinction. I mean, mammograms do not prevent cancer, but they're meant to find the one that's already there and find it while it's still a small problem. It's always a problem, but at least it's a much more minor problem.
So like the best case scenario of the worst case scenario is finding it as early as possible.
Absolutely. That's a beautiful way of saying it.
Thank you. That's really helpful to know. Can we talk about radiation?
Absolutely. I bet you guys get that question live.
So can you give us an idea? Can you give us an idea, like how much radiation is even associated with a mammogram?
Right. So I'm going to try not to get overly technical, but this is a fun answer. So radiation from mammograms is very low and it's safe. Okay. So first of all, we're all exposed to radiation every single day from natural sources, the sun, the ground, even elements in our own body. Okay. So the average person gets about 3 millisieverts. That's the unit we measure. 3 millisieverts of natural radiation a year just from living on planet Earth. Okay. So one mammogram is 0.4 millisieverts. So that's the equivalent of basically being alive for 6 weeks or so, right? So the same thing as just living. That's the amount of radiation you get. It's the same as about 3 or 4 cross-country flights. And nowadays with digital and tomosynthesis mammograms, with the techniques that have improved, they use even less radiation than the older machines. So this tiny theoretical risk of radiation exposure from mammograms is obviously a big concern. I'm sure you get that question a lot, but I really do think it pales in comparison to the amount of lives that are saved by mammogram. Studies estimate that for every 100,000 women screened annually from age 40 to 80, there'll probably be about 86 radiation-induced cancers and 11 people will die out of 100,000. Compared to well over 2,000 breast cancer deaths that are going to be prevented by that. So if you do the math on that, it's on a societal level, it's 100 times greater chance that you're going to save someone's life than you are to harm them at all with the mammogram. So again, tiny doses, essentially just a shade more than what physiological level is just from living. And I don't want to be harsh about this, but I do think some of these concerns have been overblown.
Yeah, it feels like when people bring up injuries after a car accident from wearing a seatbelt, like a very, very small percentage of people who get injured from wearing a seatbelt, it doesn't mean you don't wear a seatbelt,
That's a good
you
point.
know? Yeah.
Or the airbags.
Yeah, exactly. Exactly.
Absolutely.
Um, Thank you for explaining that in a way, especially like, so if you fly to LA twice a year, you got a mammogram,
Yeah,
we're
you
different.
got a mammogram. I don't
And
think it's any different. Yeah, right. It's not no different.
we still go to LA. Thank you so much. Okay, so Brent's dense breast tissue seems really common. I'm not sure. I would like to talk about that and if you can explain that to us. And then also, while we discuss this, if you can give us sort of like a general overview of breast anatomy. And we have some visuals to share as well. So I'm
Yes.
going to get these pulled up, and then we'll go
Sure.
through them together.
Sure. So dense breast, you're gonna hear a lot about this. So breast density, that refers to how much glandular and connective tissue you have compared to fat tissue in the breast. Okay. And this is something that's described as how it's seen on a mammogram. So this has nothing to do with how your breasts feel or their size. It's an imaging determinant. It's measured on imaging. So about over 40% of women actually have dense breasts. And dense tissue appears white on mammograms, and so do cancers. So that dense breast makes tumors a little bit harder to see. Women with dense breasts, they do have a modestly increased risk of breast cancer. They may benefit from some supplemental screening, which we'll talk about. But that's this picture is, I think, a good transition point here. So what I was drawing their attention to on the left side of the screen is when we think of density of the breast, the main cells that we're looking at are lobules, which make milk, and ducts that take milk to the nipple. This, alongside all of the ligaments and connective tissue around it, that's what makes the dense component of a breast. The fatty tissue of the breast, that's actually very dark on mammogram and pretty easy to see through. So as you age, as a woman ages, and she's no longer of reproductive age, not getting further and further away from breastfeeding and pregnancies, the breast tissue naturally tends to involute and become more fatty. But for younger patients especially, we do see that they do have dense breasts on imaging, and a lot of times for them, we're talking about what else can we do to make sure that we're not missing, especially small things. So I just wanted to show you that this is what that actually looks like, the inside of a breast, because I think a misconception is that breast is just all fat and that there's not
Yeah.
really much else in there, but it's actually breast tissue can be quite busy, especially in younger women.
Okay, so dense breast tissue is like a normal variant. Like some people have it, some people don't.
Absolutely, like I said, over 40%. So almost flipping a coin, whose breasts are going to be dense and who's not.
Got it. Do patients who have dense breast tissue have higher cancer risks, or is it just a variant?
Slightly, it can be slightly. The fact is that it goes to the adage of, like, if you have more of anything, there's more chance that something goes wrong, right? So the
Mhm.
more ductal tissue you have, the tighter it is. There is a chance that there's a slightly higher risk of developing cancer. It's not that anything that can't be managed; it's just something
Mhm.
that you need to be aware of. 65 to 70% of breast cancer start in ducts. Another 20 to 25% start in the lobules, and then there's a few very odd, strange cancers that are some better prognostic wise and some worse prognostic wise. But this is why, especially with mammograms, we want to be very careful, really looking at all this tissue from three-dimensional angles so we can see the paths of all these ducts and make sure we're not seeing any abnormalities coming up.
Got it. Another thing that we hear about a lot, like findings on imaging that can just sound kind of scary, is calcification. What does that mean? Is it something to be concerned about? And sometimes we also, like after we've had a procedure, especially if there's like fat added to the breast or if there's incision on the breast, sometimes some of those things can show up and look a little bit like calcification on a mammogram. Can you talk us through like what calcification means?
Absolutely, yes. I think I have another good visual for us here too. So calcifications are tiny little calcium deposits in the breast tissue, and they show up as small little white spots on the mammogram. They're very common, extremely common in the general population, and the vast majority of time they are benign. They are not cancer. Um, Benign calcifications tend to be larger, round, and scattered. Suspicious calcifications, that could indicate an early sign of cancer, those are typically very fine, irregular in shape, and they're clustered together. So if calcifications are found on a mammogram, the radiologist will typically determine if they need further evaluation or if they're just clearly benign, and you can just continue with routine screening. So this is a great example I found of a patient who, why mammograms save lives. So the left image of the three, the far left image, that was her regular view of her breast. So the white part where Gianna's mouse cursor is, that's the dense breast tissue, and you can see the periphery of the breast, which is more like the dark color of the surrounding room around it. That's the fatty tissue. This patient was in her 50s, so she definitely had some, you could see that the breast was starting to become more fatty and have less density. When you go through and look at this on tomosynthesis view, though, the radiologist made an excellent find. So then the second image is zoomed in, and you can see the arrowhead is pointing at two little teeny tiny white dots, and those are calcifications. So with technology, again, nowadays, we can do something called spot compression. So they squeezed and zoomed in even further. And I don't know how well this projects on the screen, but you can see there's a tiny, fine cluster of calcifications right at the arrow edge in the third picture. And this actually is an amazing life-saving catch, because this was biopsied and it was found to have ductal carcinoma in situ, which is a precursor of breast cancer. It essentially means that there were true, legitimate cancer cells in the duct, but they had not invaded through the duct yet. So we call this either a precancer or a stage 0 cancer. So this was essentially removed with biopsy. She had a follow-up surgery, but she had a very small amount of DCIS, where if you had left that for a year again, or if we hadn't seen that, or if she hadn't come for her mammogram, who knows what problem this could have turned into. So instead, this was dealt with swiftly. She did not need to undergo chemotherapy. She is in great shape. She's thriving and doing very well. So mammograms save lives, and mammograms are the single best test to find calcifications.
And Dr. Paryani, is this something she would have been able to feel? It looks really small.
Absolutely not. Calcifications, you can't feel them. And again, that was about 3 millimeters or 4 millimeters of calcifications, which is less than half the size of your pinky nail. I mean, no one's going to feel that. So
Yeah.
this was life-saving for her.
So if she would have skipped this mammogram, like this would have progressed, and maybe she then would have found it if she felt a lump. But like you said earlier, later stage, worse outcome can be difficult to treat.
I get chills. I get itchy just thinking about it. Oh, this was a great catch.
Yeah, that's phenomenal. I'm so happy for her. I'm glad that she
Me
went.
too. Me too.
Okay, so mammograms with implants. If you have mesh too, whether you have just a breast implant or if you have mesh around that implant, regardless, does the presence of device, can you sort of talk us through, like, does that change how these are done? And what can somebody expect if they're walking in to have a mammogram done and they have breast implants?
Yes, and here's another one I pulled for you all, so you can see a good visual. So mammograms, you should absolutely still get mammograms if you have breast implants. It's totally doable. It works, and it's totally fine. Mammogram technologists, these people are now trained. They're specifically trained to work with implant patients, and they see them regularly. I don't know if I need to tell Bustmob how prevalent breast implants are in society, but they're everywhere now. But there's a few things that are different. So the first thing is, and this is reflected by my picture on the left, is they'll take standard views showing the breast tissue and the implant together. And you can see the implant dominates most of the space. Now, this is a woman who had a above the muscle implant. So then they do some special Eklund views. So they're also known as implant displacement views. And during those views, the technologist gently pushes the implant back toward the chest wall while pulling your breast tissue forward. And this lets them see more of the breast tissue without the implant blocking the view. And I don't want anyone to worry, like that is a very temporary displacement. It's only for imaging. Your implant goes right back into its normal position as soon as the compression is released. And it's completely different from a surgical the implant displacement that we're talking about. It's nothing permanent. So you get typically 4 views of each breast, 2 standard and 2 with displacement, and they essentially make sure everything looks okay. You can see by the end on the right, that person has plenty of breast tissue in the field of view, and the radiologist can make a safe determination that she's okay to go home and do it again next year.
Fabulous. Go science.
That's right.
While we're talking about implants and mammograms, you mentioned this, what we're looking at is a over the muscle placement. So it's what we call subglandular within the breast tissue right behind the nipple. Does your implants being over under the muscle change how a mammogram is taken?
They still do the similar technique of the with the Eklund views and implant displacement views, but in general, I would say more breast tissue can be pulled forward when the implant is placed submuscular. But both placements are totally fine for mammography screening, and technologists know how to work with either type. I think the most important thing is that no matter where your implant is, you should continue to get screened regularly.
Absolutely. Thank you. And that visual was so helpful. So good to see it. This question is coming through the chat, but it's also a question that we had already pulled in the group. It's a really common question. How long should I wait after surgery to get a mammogram? I'm kind of going to make this a 2-part. And then should I be getting a mammogram before surgery as like a baseline, even if I'm not necessarily like 40 or 45?
Those are great questions, and I feel like these are the ones I'm probably the least helpful with today. But the truth is, it varies by surgeon. So I would say always follow your plastic surgeon's specific instructions. Some surgeons do recommend waiting 3 to 6 months after surgery to allow healing, because mammograms can look abnormal with all the inflammation and healing that needs to happen after a surgical procedure like that. And as far as an mammogram prior to implantation, I think that depends on your age and when your last mammogram was. Some plastic surgeons will have you go ahead and get the mammogram before surgery, especially if you're close to being due for one anyway. And I think this is really important to discuss with your plastic surgeon during your consultation.
Perfect. Thank you. Can mammograms hurt implants?
So by hurt, I think you're specifically mean, can they rupture? How much damage can it do? And the answer is extremely rarely yes. Extremely rarely. So this was another review that was published in 2024. It was over 20,000 implant-related reports, and I found that actually only 41 of them over 10 years were ruptures. So, but the ones that were actually confirmed in follow-up were 19. So 19 out of 20,000. That's very, very small. We don't know if that was specifically related to the procedure or if that was something that was already in the process of happening. It's just, the point is, it's extremely small numbers, but it's just slightly more than a theoretical risk. But breast cancer, I'm sorry. See, I'm so used to talking about breast cancer. They're designed to withstand hundreds of pounds of force. And the compression used during mammogram is well within what the implants are built to safely handle. But again, and I don't mean to sound like a broken record here, but the risk benefit is clear, right? Like the breast cancer is far more common and dangerous than the extremely rare possibility of an implant rupture during a mammogram. So you should absolutely consider continue doing this. And I just think you want to have the safest and best experience. Tell the mammography center well in advance, I have implants. Make sure they know what's going on. Remind the technologist again when you arrive, and go to a facility experienced with implant patients, which again is mostly everyone nowadays.
Yeah. It feels again like the seatbelt comparison of You can, technically harm the device. Like if you get into a car accident and you're wearing a seatbelt, you would still put the seatbelt on.
Right.
You'd much rather have to, swap out an implant awake and go back to work the next day than, deal with a head injury or skip a mammogram and, prevent screening for disease early and find out later.
Right.
Um,
Can
I
I say
personally,
I'm sorry. I'm sorry.
no, no, please go ahead.
I thought of something important, like, because
Yes.
I learned this actually when I was already an attending, which is weird. You'd think I would know this in fellowship, but I learned as an attending that when you want to check the structure of an MR, I'm sorry, of an implant, you get an MRI.
Hmm.
I didn't realize it's a non-contrast MRI, and
Hmm.
it can really look for the integrity of the implant capsule. But
Hmm.
I just want to make sure some people, because again, I've had this question a lot, that does not replace a mammogram for cancer screening. Okay, so MRI for cancer screening needs contrast. It's very sensitive, but again, mammogram sees those fine calcifications way better than MRI. So I don't know why that just popped into my head. I was like, I don't know
Yeah.
if we'll come to that later, but that's something I feel like everyone needs to know. Like that,
Yes.
an MRI to assess implant integrity is not a cancer screening test at all.
Hmm.
Sorry.
So important. And that is something that I did want to talk about, both MRI and ultrasound. We're on the topic. Let's just jump into it. I hear a lot of people saying, I'm not interested in the mammogram because of radiation, which we've already debunked. That was so helpful. Instead, I get an ultrasound with an MRI. And I think what's also confusing is sometimes you get a mammogram, you do the right thing, and then you get referred to that as well.
Yeah.
And then the secret third thing is also the implant surveillance, is what we call it, right? Just a regular non-contrast MRI where they are literally looking at the shell of the implant to see, is it ruptured, is it fractured, is it open, or is anything wrong with it? And that's an FDA recommendation. And so usually if you talk to your plastic surgeon, they will write an order for that non-contrast MRI to surveil the implant. But what you're saying, which is so important, is that that is not the same thing as a contrast MRI or a substitute for a mammogram. So,
Right.
what is the ultrasound and the MRI for, and how are they different and how are they used?
And I just love that you said it again that way. You're just so articulate the way you say things. I give
Thank
you
you.
credit. Because, like I said, I admitted I'm triple board certified. I'm a board certified oncologist, and I did not know that until I became an oncologist. Like about the non-contrast MRI for implant integrity and contrast
Mhm.
MRI for screening. Like that, I think everyone. The more you know that, the more power a woman has over her own health. So very
Absolutely.
important to know that. I think breast MRI, we're talking contrast breast MRI and
Mhm.
ultrasound, they're still not alternatives to mammogram. They are used in specific situations alongside mammograms. So breast MRI is definitely the most sensitive test for finding breast cancer, but it's predominantly used in high-risk women. So these are women with a genetic mutation like BRCA, if you are familiar with that, or a very strong family history. But this is used in addition to, not instead of mammography. Again, on a society level, it's not recommended for the average risk person because it's expensive, it requires IV contrast, and it does come with more false alarms. It also, as I mentioned earlier, it cannot replace mammogram because it is inferior at finding calcification. So things like early stage cancer, these little baby calcifications that we saw in that visual a few minutes ago, MRI is just not going to cut it for that. So I think that there, again, that's an important distinction. Ultrasound, that's again, it can find some additional cancers in women with dense breasts when you add it to mammography, but it's really not all that useful as a screening tool by itself. It finds fewer cancers than MRI, has more false alarms, and it's actually operator dependent. It's only as good as the ultrasonographer that's doing it. Um, Again, it does not show calcifications and cannot replace mammogram. So again, for average risk women, mammography is still the primary screening test because it's the only method that's actually data proven to save lives in the average risk population.
Fabulous. Thank you. That feels so much more clear to me now. All right, this next question. Someone wrote it and said, I found a lump in my breast after getting implants and I'm freaking out. What do I do now? What is like step one if something like that happens to you?
Um, Step one is call your doctor. Okay,
Hmm.
we actually I would I think I speak for every doctor. I would be more offended if you did not call me in that
Mhm.
situation. That if you are not bothering me, I want to know. So what we're, I would tell you the vast majority of lumps are benign,
Mhm.
but any new lump needs workup. Doctors typically recommend a diagnostic mammogram with an ultrasound. The ultrasound is meant specifically to target the lump,
Mhm.
um, and we'll do the implant displacement views, the Eklund views, um, and go from there. If it's something that's clearly benign, you move on. If it's something that is concerning, then typically a biopsy is recommended. But I would encourage everyone watching and listening to don't delay getting it checked, especially with the fear of anything related to the implants, because breast cancer screening and diagnosis work incredibly well even with implants. Like it is not a barrier.
Yeah. I think when you add implants to the mix, we have this like dual situation going on where one, women feel like we're burdening our providers a lot of times by bringing things up that might be nothing. I agree. Like, call us about everything, please.
Please.
And then two, there's this like concern about the implant and like harming the implant during screening. But like you shared earlier, I mean, we have video. You can throw an implant off the roof, you can run it over with a car, and it stays intact. And that mammogram is nothing compared to that amount of force. So these are built to last. They're meant to survive that. And I also sometimes I've heard like, I went in for my mammogram with 17-year-old saline implants and one ruptured. I feel like if that did happen, likely it was going to rupture from something,
Right.
like even a tight hug. It was on its way because it's 17 years old and they're not lifetime devices.
That's exactly what I was thinking with that study where they said that they could all, there was, looking at mammography related
Mhm.
implant, we don't know how much of that was already brewing, like no, we
Right. Yeah.
really don't know. And in the case of a 17-year implant, that thing had a great run. I mean, give it
Yeah.
credit.
It,
It
it did. It was never meant for this and it did it anyway. So it's an Olympian of sorts and
That's right.
it's time to swap it out. Um, can we talk about self-breast exams?
Yes.
Should we be performing them? Is it different with implants? How often should we be performing them?
You're asking me the hard questions today. But I think that was just a controversial question because
Mhm.
there's so many like different, you read on the internet, you're going to get a different answer depending on what you read.
Yeah.
And actually a lot of the organizations, they've gotten away from the,
Mhm.
when I was a kid in the 90s and 2000s, you would see commercials on TV for
Yep.
do yourself monthly self breast check. But a lot of the organizations today have gotten away from it, and instead they're encouraging something called breast awareness. And this is actually what I do with my patients who, remember, I don't see anyone that it has a normal risk patient, right? I'm saying
Mhm.
all high risk and cancer patients. So
Yeah.
with these patients, and what I tell my own wife, my own family is choose, if you choose to do so, which I actually do encourage people to do it at the end of your period when your breasts are the least tender, and especially if you have implants, learn what that implant feels like.
Mhm.
Learn that it's going to be smooth, it's going to be firm. Learn what's normal for you. Most importantly, what I tell people, and I deal with a lot of cancer patients who had reconstruction, they've had implants after mastectomy. But what I say is feel for the edge of the implant, kind of get a gauge for the plane that it sits on, make sure nothing's like off plane, there's not a lump underneath, there's no unevenness. Very important to look for skin changes, nipple changes, that being the shape of the nipple, whether it inverts or retracts, if anything new like that comes up. And please be sure to report any nipple discharge, especially if bloody. These things are all important to just know the landscape, know the architecture of your breast, and just be aware enough to say, hey, I think something's different,
Mhm.
because we will take over from there. Like, come
Mhm.
see us, let us help you figure it out. And I just really think no one's ever won a Nobel Prize for not giving someone an ultrasound just to make sure everything's okay.
Yeah.
I mean, it's not that hard for us to
Right.
reassure and make sure somebody's all right.
Yeah, and I think even little questions are always worth asking, even over an email. Like you said, changes in nipple, like if the nipple becomes inverted, I think sometimes to avoid anxiety, we want to explain things away. Like, oh, I gained weight, maybe it's making the way that my nipple look different,
Right.
but always worth it to ask, right?
And you're not only just looking for cancer. I mean,
Mhm.
breast abscess, like
Yeah,
infectious stuff like that. That mammogram can help, and ultrasound, breast imaging.
yeah.
Doctors can help diagnose all of that. I mean, and it
Mhm.
all needs attention.
Yeah, absolutely. I mean, even, things that are more likely to happen than cancer, like capsular contracture, will make the breast look and feel different. Or a rupture plus capsular contracture, you can get a little bit of like squeezing of the implant that can end up with a little like gel bubble off of one side, and that can feel like a lump, but always worth it to ask, always worth it to take a look.
The other thing that really throws me off and it ruins my day sometimes is fat necrosis.
Yes. Can you talk a little bit about that and what that looks like on mammogram?
Necrosis is it's a lump, and it's a round lump, and
Mhm.
tumors are also round lumps. So but typically when someone's had a big, especially in cancer, if someone's had a big breast surgery with lots of moving of fat, and fat in general in and of itself just doesn't have a great blood supply compared
Mhm.
to muscle or other organs like visceral organs.
Sure.
So sometimes during the healing process, you remember when a breast is healing back together, it's not just the skin level that's healing. It's layers. So you've
Mhm.
got the bottom layers too. Those fat layers, they sometimes don't heal all that well together. And when fat doesn't heal well and dies off, it kind of curdles. I know that's kind of
Mhm.
gross. I'm sorry, but it curdles and forms a ball. And a ball that you feel in the breast is never something that we take lightly. So
Yeah.
very common, especially in mastectomy patients and people who've had reconstructive surgery, deep flaps where they've actually done fat transfer. I mean,
Mhm.
that fat, not all that fat is going to make it, right? So
Right.
it's
Yeah.
a benign condition. It typically just dissolves away over time, but very important to know. But the nice thing is also fat necrosis has a very, very specific appearance on
Mhm.
mammogram and ultrasound. So like, a radiologist can say, you're fine, go home,
Yeah,
bye, you
that's
know?
great. I know it's something that can happen even with elective breast
Mhm.
surgeries, or like with fat grafting is becoming more common. Sometimes we're
Sure.
we're grafting fat to the breast to hide implant edge, or doing something called auto augmentation, where the fatty breast tissue is being sort of like displaced superiorly higher in the breast, and then there can be changes on just regular mammogram. I've seen patients text in or say, hey, like my mammogram looks different than it ever has, but I also had a lift last year, and this is my first image since then. Um, so super good to know. And fat necrosis sounds scary, but thank you for explaining it, that it's just something that can happen. Are you ready to get into truth and myth?
Oh, this should be fun.
This one's going to be fun. All right. Mammography causes cancer. True or
Yes.
false?
Oh, false.
False.
Mammograms, strongest false. I could scream it from a rooftop. Mammograms do not cause cancer. So yes, mammograms use a very small amount of radiation that we talked about, but the dose is extremely low. The
Mhm.
risk is minimal. Again, for every 100,000 people you screen over
Mhm.
40 years, maybe 80 people will have a radiation induced cancer, 11 deaths. In
Mhm.
that same population, over 2,000 people will not die because they've done screening. It is
Yeah.
a 200-fold increase in the amount of people you will save versus the amount you will harm. So we talked about these radiation doses are minimal. Modern technology makes them even less than it ever was before. The doses are well below any published safety limit that what we should ever even really think about. I just would encourage women, do not lose another wink of sleep over
Yeah.
this.
What I think is interesting is when, let's say you're, going in and you're having like a more formal kind of X-ray type study. It's not uncommon to see those people wearing lead. You
Right.
don't see mammogram technologists ever wearing lead.
Nope.
And they're doing that all day. They're shooting those X-rays.
Right.
And so if they don't even have to wear lead to do their job that they go to 5 days a week, I think that speaks a lot to the safety of something that we do once a year.
That's a great point. Actually, our cancer center, we had a big sign up front because we were getting questions from patients about that, like, why are you all not wearing lead? And
Hmm.
it was a big Duke initiative. It was in 2024, I think, that where
Hmm.
we were like, hey, it's okay. I
Yeah.
know that sounds
Yeah,
weird,
it's
but
okay.
you're okay. It's fine.
That's great. I love
You
that.
can get
I love that
way
Duke
more.
posted that.
I'm sorry.
I love that Duke posted that. Like, don't
Yeah,
be
yeah,
worried.
absolutely. Right at the door, actually, right at the door. But it was, CT scans,
Yeah.
all of these things, like they're much different tiers of what we're talking about
Yeah.
than mammography.
That's great. All right. Next, truth or myth? Breast implants cause cancer. And I'd like for you to talk about BIA ALCL if you don't mind.
Yeah, sure, absolutely. I think that's something I haven't seen in a while.
Mhm.
So that's a myth. Breast cancer is not directly related to implants. No. Multiple large studies have shown that breast implants do not cause cancer. They've shown that the risk of breast cancer is the same in women with implants as in those without implants. Um, so what you said, BIA ALCL, which is breast implant associated anaplastic large cell lymphoma. Remember, that is not a breast cancer. That is a cancer of your immune cells that can
Mhm.
develop in the scar tissue around the implant.
Mhm.
So this type of lymphoma, BIA-ALCL, it is very rare, about 20 cases per 100 million women in a year. So incredibly rare. I might have you help me with this part afterwards, but it's
Sure.
mostly in women with textured implants. And
Mhm.
my understanding is that those are not used all that much in America anymore. I believe a big brand was recalled.
Allergan
Yeah, in
had a
2019.
biocell device that was textured, and it was just noted that there was an increase of this specific kind of lymphoma, and they were removed from the market. I think also interestingly is that the treatment is removing the implant.
Right. It develops, 7 to 10 years later.
Mhm.
It presents with a new swelling, like fluid buildup or bump around the implant, like, years after surgery.
Mhm.
And the point is, it is very treatable when caught
Mhm.
early. Most patients do very well with it. The treatment involves removing the capsule and the implant. So again, this goes back to what we said earlier. If you have a new swelling, new lump, change in the breast, or anything, just call us, please.
Yeah, and I know, so because of those specific implants, I think it caused a lot of fear among any implant that didn't have the smooth silicone shell. And especially now they're new to the US market, but not new to the global market, the Motiva implant. Their shell does have a notable feel to it. They call it something else. They don't call it a textured implant. They don't consider it to be a textured implant because of the degree of what that texture is. But in 10 years so far of surveillance data, these implants are not at all associated with BIA-ALCL. And it seems like the only ones that were the Allergan BioCell that are no longer even available on the market. And that we have had zero instance of this specific kind of lymphoma with a smooth implant or any other device on the market. So to me, that's very, comforting. It's a thing of the past, we hope.
This is my 6th year here. So this is probably my 8th or ninth year of just doing nothing but breast oncology. And I feel like I've probably seen somewhere around 10,000 unique cases, and I think I've only heard of one.
And you're at Duke, so you're not at, a community cancer center. You're at like a
Heard of
cancer
one.
center that people seek out.
Yeah. Right, right. So no, and it's good. It's important to raise awareness. You
Yeah.
should be aware, but the point is, this is not a breast cancer. It's
Mhm.
incredibly rare, and the main offender isn't even in our presence anymore.
Yeah, not even on the market. Can we talk about Switzerland? Switzerland gets brought up a lot.
You taught me about this.
There's a specific like blog that gets shared sometimes, that is essentially saying like, Switzerland is broken up into, they call them cantons. They're like states or boroughs, and they each are responsible for their own public health initiatives and, when they screen, how often they screen, if it's publicly available, if there's costs associated, all of that. But the point is that sometimes we see these arguments that, well, countries that screen less frequently have lower rates of cancer. Therefore, it must be that the mammogram itself is inducing breast cancer in women.
I
Myth?
apologize. I had the flu, so I'm gutting it out. But Actually, I thought this was when you told me, when we were talking about me coming on and
Yeah,
doing this talk with you, you were like, one thing I want to talk about at some point is Switzerland. And I was like, what? What are we talking about? So now, though, I became an expert on Switzerland.
thank you.
I did research. I brought receipts with me. Okay, you ready?
Thank you.
So so this is interesting. So Switzerland in 2014, the Swiss Medical Board recommended against introducing new mammography screening programs as a mandate in
Mhm.
Switzerland. That's different than banning mammograms. That's what I read. I actually started reading these forms. I was like, a lot of people are like, they banned mammograms. Like, first of all, no, they didn't. That's a big
Never.
key distinction there. Yeah. So that recommendation was highly controversial, and the reason I didn't know about it was because I was too young. Okay, so that's why I didn't know about it. So, but it sparked intense debate in the community at the time and the media, which now I've gone back and seen some of the famous oncologists I know have talked about it. And so here's the analysis, that the criticism of the analysis. So first of all, the Swiss Medical Board used a very short 13-year time frame to evaluate the benefits. So they said, okay, we've looked at this for 13 years. It doesn't really help you, so we don't need this. And my point is, in 13 years, you're going to significantly underestimate the lives saved by screening. That's just not long enough. Like, I told you, I'm in my early 40s. I'm not looking at my life till when I'm in my mid 50s. Like, I
Mhm.
care about my life longer than that. Like, we're
Right.
all we're all living longer, looking younger, like doing better than ever. We live now in our generation better than any generation that's ever come before us. So why are we using a limited 13-year worldview? Makes no
Right.
sense. So when researchers went back and reanalyzed this Swiss data, using a lifetime perspective instead of just 13 years, they found that screening would save 444 life years per 10,000 women over their lifetimes. So you've lost 444 years of life every 10,000 women, compared to what the medical board said, which was only 56 years. So they drastically underestimated the benefit. They also overestimated the harm of false positives. So they said, they assumed that it was a 5% annual quality of life loss from false positives. And international research said it's only about 1%. So
Got it.
overstated. Overdiagnosis, they claimed, was in the 13 years fourfold higher than what research has analyzed. So again, a quarter of their estimate of overdiagnosis. So again, I think it was a deeply flawed analysis that the Swiss government used. They did not ban mammograms, and what I recently learned is that most Swiss cantons have organized screening programs, and their data does still continue to show a benefit. As they published in 2024 that their women aged 50 to 69 in the cantons with organized programs had significantly smaller tumors and less lymph node involvement compared to women in cantons without those organized programs. So again, that's what we said. Mammogram is going to catch you at an earlier stage. But
Mhm.
but guess what? Guess what that, like, what does that mean? Like, what's the impact? Like, the people in Switzerland who are skipping screening, and not just in Switzerland, but people who skip screening, look, they're going to get breast cancer at the same rate,
Mhm.
but their cancer is going to be found at a much later advanced stage. They're going to have a higher death rate from breast cancer.
Mhm.
They're going to need more aggressive treatment. Like, lymph nodes oftentimes means you're getting chemotherapy. You don't want to meet me. Like, you don't want chemotherapy.
Yeah.
That's the worst thing that I can do to people. And I hate doing it, but it does save lives.
Mhm.
So again, I said this earlier, but the goal of screening is not to prevent cancer. We can't do that. The goal of screening is to find it as early as possible when it's in its most treatable form.
Mhm.
So avoiding it is not going to protect you from cancer. It just means that if you get it, it's just going to be harder for me to treat it.
Mhm. It's so, so important to hear. And I think it's one of those things where sometimes medicine is wrong and their initial recommendation ended up being wrong.
Right.
It was just a severe miscalculation that we don't know, like 2014 wasn't that long ago. We don't know what the long-term implication will be. Like Switzerland could end up being like the poster child of like public health disaster,
Right.
further down the line when we have more data to be able to look back at. Um,
It could be. You're right. I've already seen it in a shorter term. I mean, I think a lot of people here, what hits close to home was COVID.
Skipping
When,
screenings.
yeah, I feel like only in 2025 did I start seeing a lot more like stage 1
Mm.
again. Like for 2021, 2022, 2023,
Later stage.
a lot of node positive. I mean, it's emotionally, it took a toll. I mean, it really, it took a toll on all of us.
How sad. Wow. I just hate to hear that for women. You know, it's
Me too.
truly, truly, truly devastating.
Me too.
Um, I want to talk about thermography. I have a personal beef with it.
Me too. That's why we're friends.
Yeah, I have big problems with it. I could talk at length about this, but I've never seen somebody recommending thermography who wasn't selling it for a cash price.
Right.
And I've also never seen a oncologist or a medical doctor recommending thermography.
Right.
Can you talk to me about thermograms? What the heck are they? Are they
Right.
good? Are they bad?
So the first thing I'll say boldly is that thermography is absolutely not an acceptable substitute for a mammogram. And I get this question a lot. I've had patients bring me their thermograms on a disc and ask me to read it. And I'm like, well, you know, different conversation for a different day. But so thermogram uses infrared cameras to detect heat patterns in the breast, and it's based on the idea that cancers might be warmer. So why doesn't it work? Number one, and I ask you this about any snake oil type claim, is show me any data. Like if it was worth it, put it in a trial.
Sure.
Thermogram has never done anything in a clinical trial. It has not been proven to save any lives. Studies going as far back as the 1970s have shown that it misses 25 to 30% of breast cancers. That is enormous. That
Yeah.
is an enormous failure rate.
Yeah.
It produces a lot of false alarms in women without cancer. It again, and this keeps coming back. I showed that screen with the calcifications. I think that's powerful. Like that's a
Yeah.
woman whose life saved. Thermogram doesn't find calcifications. I mean, it's going to find a lump. Maybe it's going to find a lump, but it can't see calcifications. It's not FDA approved, and the organizations that have not recommended it specifically are pretty important. This is the FDA, the American Cancer Society, and the American College of Radiology. They have not recommended thermogram as a replacement for mammography. And you can't even say this is about price, because like you said, it's not like, oh, well, they're trying to sell you something. Mammogram is way cheaper than thermogram.
Yeah.
So it's
Yeah.
not even about money. Like this is honestly, no, thermogram, just no, no.
A thermogram will never be covered by insurance, so it is always going to be a cash price, and mammogram is considered preventative, so
That's right.
frequently
Even
covered.
even the most optimistic new studies on thermogram are still just demonstrating inferiority to mammogram.
Yeah. Yeah. And especially combined with what you shared about radiation, it seems like you're foregoing a low risk, low dose of radiation to increase your risk of missing something, or a false positive, which is scary too, like a very high percentage of false positives that's going to send you down the rabbit hole. And correct me if I'm wrong, a false positive on a thermogram is still going to earn you a mammogram.
That's exactly right, because you can't do a thermogram assisted biopsy.
Right.
You sure can do a mammogram assisted biopsy, which is
Mhm.
called a stereotactic biopsy. That's actually how you would have that be done anyway.
Wow. So same endpoint,
Exactly.
possibly delay of care.
And a thinner wallet.
Yes. Oh, I hate to hear this. MRI with ultrasound, we talked about this a little bit earlier.
Right.
Safer alternative compared to mammogram or different thing?
It's like a plier versus a screwdriver, right? Like I
Mhm.
said, like I think it's a very good tool. I use it a lot. Um, I don't know that you need it in the average person, but certainly if you have a strong family history, if you have a genetic mutation, and if you have a personal history of cancer, these are not bad ideas, and the decision should be individualized with your doctor. I think the problem with MRI is claustrophobia, number one. A lot of my patients need some kind of sedative just to get through. They're like, give me something. I can't be in that tube for 40 minutes. And I feel bad for them, but you got to do what you got to do. Number two, gadolinium exposure over time seems safe, but there's always questions on all of this. Number three is insurance coverage. MRI is very expensive, so it's just not, because it's not routinely included in guidelines. I don't know that it gets covered for everyone. So it has some limitations, but it is a powerful tool that I use quite often. A lot of radiology centers offer a screening mammogram for, I'm sorry, a screening MRI for a cash price. So I do know that that's an option for people who are like, you know what, I can afford it. I want that peace of mind. I want to do it. So that is an option out there.
Got it. An interesting question came through in the chat asking about BIA-ALCL. The first question is it able to be seen on mammograms? And if so, should patients with implants start mammograms earlier than 40? I'm not sure if this person has like a textured implant, a biocell textured implant. But if they don't have one of those implants, they are not considered higher risk of BIA-ALCL. Is that correct? So they wouldn't necessarily need to screen earlier. But I
Uh,
am interested about, does any of this show up on mammogram?
It can. It can. I think clinical symptoms are going to be the much more, because it can be subtle, right? It just depends on how long something's been brewing. But the findings of these things like inflammatory capsule changes, certainly capsular contracture, these are subtle on imaging, honestly. So I think it just depends. On mammogram, I don't know that it's the most reliable thing. I think MRI would probably be more likely to show you that there's some inflammatory process in the capsule, but that is not easy to detect by the diagnosis. That diagnosis in general is not an easy imaging diagnosis. That's more of a clinical diagnosis.
Got it. That's super helpful.
In the one case I've seen in my,
Yeah. So someone you love, a woman you love, would you ever tell her to not get a mammogram? Got it. And that's the advice you would give your family.
my wife had to get her mammogram on the day after her 40th birthday.
You were like, we're not messing around.
And I was like, next day, come on, let's go.
I love it. And how was her
By this
experience?
disease, I've been very traumatized. It's not. Um, I can smile about it because it's my passion to help people with it,
Mhm.
but breast cancer is really serious. It is
Yeah.
a huge public health problem,
Yeah.
and I still feel like people don't realize. Like I can look at patients and I look at their husbands in rooms and I say 1 in 8, and 1 in 8 is shocking. I mean, that's 12.5% incidence in the
Mhm.
population. That is horrible. It is a horrible disease, and that's one of the reasons I get up in the morning, is because I just hope one day we just don't have to deal with it anymore.
We're so glad you do. And we're just so appreciative of your time today. That was everything. Um, so
Really, I appreciate you so much for having me, honestly. I hope the discussion has helped clarify some of the questions and concerns about screening, especially as it relates to implants. I think the science is clear. Mammogram saves lives. Implants don't prevent you from getting screened, and the myths that you may encounter online just simply don't hold up to the evidence. But I feel like if people take one thing away from this talk today, it would be that, early detection is our most powerful tool. Um, please continue to prioritize your breast health, and do not hesitate to ask your doctors questions. Like, we really want to hear from you.
Absolutely. Um, if anyone in our community is looking for breast cancer care or they know somebody who is looking for cancer care, are you accepting new patients?
Absolutely, we would love to help. I mean, in oncology, there's no such thing as not accepting new patients.
Yeah,
We're always here to help.
fabulous. And then two places that patients can reach you if they want to stay connected online. X, formerly known as Twitter, you're at VP Onc, ONC, MD.
Yep,
And on Instagram, V Paryani 02.
that's right.
Um, Thank you so, so much for your time today.
Thank
This
you.
was so empowering. Bustmob is always going to, prioritize evidence-based education, facts over fear. We know that when women are empowered with information, that they are then able to make the best possible decisions for themselves. And we are on this mission to offer this open access education brought to us by experts and explained in plain English, like you just did. So our Facebook community right now is almost 120,000 women strong. We're also across other TikTok and Instagram social channels. So if anybody is ever interested in joining us in our Facebook community or finding us online, that's where you'd find us. I would really encourage anybody who is watching this, if you learned something today, if you know somebody with breasts and you heard something that they need to hear, please share this. This is going to be available on our YouTube. You can shoot it out into the world and just make sure people are getting a hold of it who really need to see it. We've got to get in front of this bad information and pull away the fear, because I think the truth is so much less scary and so much more empowering than any of the scary stuff we have ever heard. So, Dr. Paryani, I cannot thank you enough for being with us today and for your time, especially while being sick. So gracious of you. Really want to wish you a wonderful day, and all of the women in our community as well. And we will see you next time.
Take care. Thank you.